tumors that are heterogeneous in their genomic makeup, and which means multiple different driver alterations, suggests that there are different populations of cells that will respond differently to various therapies. It also has implications for targeted therapies. So, for example, if you have a patient with intrahepatic cholangiocarcinoma and a biopsy shows a particular target that can be used for treatment, that may well be helpful with a population of cells with that alteration, but it's not going to affect other populations with different driver alterations that are completely unrelated to that pathway. So it has implications for why patients fail treatment and for why single targeted therapies are not going to necessarily be as effective as we'd like them to be. Firstly, the concordance level between the original primary tumor and either recurrent tumors after resection or metastatic lesions in intrahepatic tumors was quite low at around 40% or thereabouts. It's much higher in the extrahepatic biliary cancers, which is in keeping with what we believe how these tumors evolve. Intrahepatic tumors can evolve from multiple different sites of origin, multiple different cells of origin, I should say. So therefore, we'll have different subpopulations of cells potentially, whereas the extrahepatic biliary tumors generally arise almost entirely from the biliary epithelium, and so there are fewer, different or alternative sort of cells of origin that can give rise to these tumors. So the finding of the lower concordance rate in the intrahepatic tumors goes along with our current understanding of tumor biology. The implications of that are in a patient with intrahepatic cholangiocarcinoma who is being treated with a particular therapy or combination of therapies. If the therapy is no longer being effective, then it may be worth repeating a biopsy to see if there's a new sort of dominant population of driver alterations that may lead to a change in treatment. The overall concordance was 47% compared to 60% in the extrahepatic cholangiocarcinoma patients. And while the mutational concordance was 58% and 84% respectively, so significantly higher in the extrahepatic tumors. One interesting finding was that with the small number of patients who had IDH1 or 2 alterations or FGFR fusions, which were entirely restricted to the intrahepatic cholangiocarcinoma patients, there was 100% concordance between the primary and the advanced disease, meaning in those patients who had these alterations in the primary tumor, they were all detected as well in the advanced disease specimens. Now, interestingly, there were 2 patients who had an FGFR2 fusion and an IDH1 mutation detected only in the advanced disease biopsy. So another reason and these are both targetable mutations, and, with approved therapy, approved drugs. So another reason to consider a repeat biopsy at some point in the course of a patient's disease, because you may find an actionable mutation in the second biopsy that wasn't apparent in the first one. Yes. So currently we have we are at Memorial Sloan Kettering Cancer Center. We are leading a multi-center institutional international study looking at the primary outcome of this trial is to look at the efficacy of hepatic artery infusion chemotherapy combined with systemic therapy in these patients. But built into this trial are a number of correlative studies aimed at addressing the issue of heterogeneity. So as part of the trial, patients, before they start treatment, patients get multiple biopsies of the primary tumor, and we'll have all of those biopsies sequenced. And in addition, there's a mechanism built in to biopsy these tumors when they progress. So we hope that this study, which will also look at circulating tumor DNA as well to see how that might help in management, will shed more light on the issue of heterogeneity and how it plays a role in patient outcomes. So I think it will show a benefit, first of all, to the regional chemotherapy to treat these patients, which we have used in prior studies, and appears to show better efficacy I'm sorry about that. Let me turn my phone. It appears to show better efficacy than systemic therapy alone. So we believe that it'll establish a place for hepatic artery infusion chemotherapy, firstly. I think it will also show that the benefit of multiple biopsies to get a better characterization of the genomic landscape of a patient's tumor. I think it will help define the role for circulating tumor DNA. And we're also using radiomics as an investigational tool to study these tumors and try and correlate the findings on these radiomic studies with the genomic characteristics of these tumors.